Good afternoon. I'm Julie Freischlag, and I'd like to welcome all of you to the ACS, American College of Surgeons Surgical Healthcare Quality Forum that's being presented here today at Johns Hopkins University School of Medicine. We want to welcome all of you for coming and being here. We're going to have some wonderful talks by Senator Cardin, as well as our panel. At the end, there'll be an opportunity to ask some questions. So please stay to ask your questions at the end. I'm really delighted as a regent of the American College of Surgeons to be moderating this session on surgical health care as we look at outcomes from surgical interventions and how we can do better. If you look at the four guiding principles of continuous quality improvement that are manifested by the American College of Surgeons, the first is making sure we have high standards. This is individualized by the patient, backed by research, and you'll hear that from the panel today. You also need to have the right infrastructure, the right staffing levels, specialists, equipment, and checklists, which we have really manifested here at Hopkins as well across the country to make sure patients are taken care of safely. Third, you need to have rigorous data from the medical charts backed by research, looking at what happens to patients as they leave the hospital, and it needs to be continuously updated. And lastly, but not least, of course, is verification, really having external peer review and creating public assurance that we're taking the best care of our patients. All of you have these four guiding principles on your cube sitting in front of you that you can take with you to remember how we can continue with continuous quality improvement. The potential cost savings, if we do adopt to the ACS NISQIP guidelines, really show that we can prevent complications and improve care and reduce costs. The reduction in complications can be in the hundreds, the average cost for complications is in the thousands, and the average savings per hospital can be millions of dollars as we prevent complications. Potentially yearly savings across 4,500 hospitals that participate in NISQIP can be between $13 and $26 billion, with an estimated total savings over a decade approaching $260 billion. So and we found common ground as we look to prevent complications in our patients, where we want higher quality care, lower cost, and this is really where a quality improvement program can make that happen. And we found this common ground for healthcare reform. I would like to now show you a movie that sort of describes some of these things from the American College of Surgeons. So now it's my pleasure to introduce Mr. Ronald Peterson, who's president of Johns Hopkins Hospital and Health Systems. Mr. Peterson.
Well, thank you very much, Julie, and good afternoon to all. I'd like to begin by welcoming those who are not from Johns Hopkins. We have several people, of course, who are gathered here today from Hopkins, but to those of you who have come, we appreciate your presence, and we hope that this will be an interesting day for everyone. We're really honored to partner with the American College of Surgeons to host this important and timely forum on surgical best practices that improve outcome and reduce costs. Hospitals and health systems, as most of you know, are very eager to identify and use the tools that can help improve patient safety because, as we all know, one adverse event is too many. And in recent years, we have made progress, but few of us believe it is coming quickly enough. And that's why Hopkins recently had the opportunity to found the Armstrong Institute for Patient Safety and Quality, which is designed to rigorously apply scientific principles to the study of safety for the benefit of all patients, not just those who are here at Hopkins. As a matter of fact, our inaugural director of the Armstrong Institute, Peter Pronovost, who many of you know, had hoped to be here, but his own mom had surgery up north, and so he traveled to be with her and extends his best wishes for a successful forum. Now, improving quality goes hand in hand with eliminating disparities. And no one knows this better than our distinguished guest speaker, keynote speaker. Senator Ben Cardin has been a longtime friend of Johns Hopkins, a stalwart supporter of biomedical research, and a true advocate for patients. He has much to be proud of during his long tenure in Congress, but among his most recent successes is this. Senator Cardin authored a provision in the Accountable Care Act to establish offices of minority health in 6 agencies of the Department of Health and Human Services and elevate the NIH's National Center on Minority Health and Health Disparities to an institute. Here in East Baltimore, we strive to reverse deep and long-standing inequities in care and have worked closely with Senator Cardin, who has raised the profile of this issue by shining the national spotlight on efforts to address racial and ethnic disparities in care. Senator Cardin is nationally recognized as an expert in health care policy. He served on the powerful Ways and Means Committee in the House and currently is a member of the Senate Finance Committee, home to all critical Medicare policy decisions. Now, after spending 20 years in the Maryland General Assembly and yet another 20 in Congress, he is someone who truly needs no introduction. We are very lucky to be represented in the U.S. Senate by a true statesman with a keen political mind and a deep love for the state of Maryland. So please join me now in welcoming to the stage Senator Benjamin Cardin.
Ron, thank you very much. It really is my pleasure to be here. Ron Peterson's one of my heroes. What he does here at Hopkins, I don't want to trade jobs with him. I think academic politics can be as difficult as politics in Washington. And dealing with the hospital community and the medical community, Ron has provided the leadership in which Johns Hopkins thrives as the best in the world. And it's just an honor to be here with you, Ron. And again, I congratulate you. We're here to talk about quality in surgery. And I experienced that firsthand in visiting a friend who was underwent surgery here yesterday at Hopkins before coming over here, and he's doing extremely well. So thank you, doctors, and thank you, Hopkins, for the extraordinary leadership that you provide, not just the people in our community, but throughout the world. As I told the panel ahead of time as I walked up, it's hard to intimidate a senator, but you look at the brain power in this room, and I am intimidated. So no questions will be asked of me about surgical issues. I just want to make that clear. The second ground rule is that I refuse to answer any questions about power outages. So I'll just get that out of the way also. I'm now on my third day at home without any power, so I joined some of you in the room. We're making new friends in visiting homes for showers and things like that. So take advantage of this opportunity to get to know your neighbors better. But we've all survived Hurricane Irene, and we were spared a lot of damage, but there's still a lot of inconvenience that's out there. But it's great to be here on this subject. This subject is one that I think is critically important to America. And Ron mentioned the backdrop of my experience in Congress and in the state legislature. And I am very proud of Maryland. I think Maryland, the hospital system in Maryland is, I think, the best in the nation. And I think hospital care in the United States is the best in the world. If you have a complicated illness, if you want to train your doctors, you're going to come right here to Johns Hopkins. There's no better place in the world. For health technology, there's no country that has done more in advancing health technology than the United States. So I come here to say first that I am proud of what you all have been able to accomplish. And I come here from Washington to say thank you. I know Washington has a strange way of thanking you in health care, some of the things that we do in Congress, but I mean this. Thank you for dedicating your lives to helping others, to building upon the great tradition of the United States in health care, and developing the way that we can innovate in health care like no other country in the world can do, where you can discover ways to deal with illnesses and to prevent illnesses that were unthinkable just a few years ago. And it's that type of creativity that we want to encourage at the national level. The interesting thing is that although we have the highest quality health care in the world, there are a couple other areas that we're not as proud about. And we need your help to figure this out. We are the most expensive nation in the world by far on how much money we spend in health care. No other nation comes close to us on a per capita basis as to the amount of dollars that we spend in health care. It's not sustainable. We are having budget battles in Washington. Perhaps you missed this, but we had a little problem in Washington this past month about dealing with our budget deficit. And we almost missed raising our debt ceiling, which would have caused the United States to default for the first time in our history. We were able to get through that crisis in a very ugly way. And the truth is that for reasons that I'd be glad to go over, we do not have sustainable budgets in Washington. And we need to figure out a way to bring down expenditures. Now, one of the targets, two of the targets, would be Medicare and Medicaid. But you can't bring down the cost of Medicare and Medicaid to the federal taxpayer without shifting cost, unless you bring down the cost of health care. And that's been our goal. Our goal is to figure out how we can do things more cost effectively in health care. That's exactly what you were talking about. As I looked at that slide, the thing that caught saving lives is number one. But the $250 billion caught my attention. That's a lot of money, $250 billion. That could go a long way. That's just in surgery, in dealing with costs in health care, that we need to be able to capture to be able to maintain the excellence that we have in health care. And then to deal with the other challenge that's out there that we have not figured out how to deal with. And that is access to care. Too many people don't have access to the quality care that's offered here at Hopkins for many reasons. Partly is because so many people don't have health insurance. Many people don't have facilities in their community. Many people don't know what they need to know about their health care needs. All of that needs to be dealt with. As a result, when you look at health care indicators in the United States, you see an infant mortality rate that baffles the country that provides the highest quality health care in the world. Why is our infant mortality rate so high? And when you look at it, we rank with nations that are in some cases third world nations on infant mortality here in the United States. You look at health disparities that Ron Peterson talked about. You look at what has happened as far as racial differences in this country or socioeconomic differences, And it raises questions as to whether we have the right health system in America, even though we have the highest quality care. And if you don't have the right system, you can't maintain the type of quality that we have. So you're going to be talking today about one aspect of that with this panel, excellence in surgery, at the place where this subject really was invented, how we can understand surgery, do it better, pass it on to future generations of surgeons. That's what Johns Hopkins founded in medicine. You're at the right place to do this. The Congress and the President tried to do something about this last year with the passage of the Affordable Care Act. And I want to talk a little bit about that in the last Congress. It's gotten a lot of talk about it. A lot of people saying, was it the right thing to do or not? There's those who want to repeal it. Those who think it was wrong for us to get involved, the federal government, into a universal type of health care system. So let me give you one senator's view, a senator that strongly supported the Affordable Care Act, as to what we were doing in the passage of the Affordable Care Act in the last Congress. The first statement we were trying to make is that access to health care should be universal. That health care should be a right, not a privilege. Every other industrial nation in the world have health policies that reflect that value, that health care should be a right, not a privilege. By the passage of the Affordable Care Act, we were trying to say at the national level that America states as a matter of principle that every American should have access to health care. It should not depend upon whether you work for a company that provides you health insurance. It shouldn't depend upon the size of your company. It shouldn't depend upon your wealth. Everyone should have access to health care. So we went about looking at small businesses and found that small businesses pay 20–30% more for the same insurance as large companies. That was changed in the Affordable Care Act. So small business owners can provide the same type of health coverage for their employees at the same cost as larger companies. We looked at individuals who currently don't have health insurance, many of whom would find it very difficult to afford to buy health insurance on their own. And we made that health insurance coverage affordable. We looked at their income and said, look, up to whatever we think is right, we will help you finance the purchase of your health insurance, because everyone has to exercise accountability and be within the system. We looked at the improvements to Medicare and said Medicare is a great program for our seniors and our disabled, but you know it has lots of gaps. One of the gaps in the Medicare program is what we call the coverage gap for prescription drugs, the so-called donut hole. If you fall within that after spending a couple $1,000s, you're on your own for the next couple $1,000s of medicine. Well, many seniors could not afford that. So in the Affordable Care Act, we start to close that coverage gap. Started with 56,000 Marylanders who received a check in 2009. This year, we're going to be providing a 50% discount on brand name drugs for those who fall in the donut hole. And by 2020, we eliminate completely the coverage gap, so we have continuous coverage for our seniors for the medicines that they need in order to stay healthier. We also provided reimbursement for the first time for the wellness exam, the annual physical. Almost 10,000 Marylanders have already taken advantage of that benefit under the Medicare system. And perhaps the most important thing from the Medicare perspective is that the Affordable Care Act extends the Medicare solvency by 12 years, making it much more sustainable for the future. All that was done in an effort to expand health care access in America, to deal with the access issue. But we also dealt with the cost issues in the Affordable Care Act. And I'm going to be urging you, and I was very pleased to see this in the presentation, cost issues are going to drive a lot of health care decisions. We have to be cost conscious and have to get better value for the dollar. The Affordable Care Act, according to the Congressional Budget Office, an agency that is very well respected by both Democrats and Republicans, and which both Democrats and Republicans will take issue with. But the Affordable Care Act was scored by the Congressional Budget Office as saving the taxpayers of this country several $100 billion during the next 10 years and over $1 trillion during the next 10 years. So that we're bringing down the cost to the taxpayers, something that we need to do in health care, not just by dealing with Medicare and Medicaid, but by dealing by health care costs generally. By using a universal model and getting around 32 million Americans with health insurance, we really start to bring in efficiencies in the health care system. I don't know, Ron, how you can run an emergency room with so many people that use it for their primary care. They have no other choice, so they come into your emergency room. You must treat them. And in many cases where they have no health insurance, that's what they use. And then they don't pay their bills. Well, that's a very inefficient way to run an emergency department. You have no choice. You're a community asset. You're a community institution. Your doors are open to all. But people who don't have health insurance, who aren't in the system, will do anything they can to take care of their family needs. And they know that you're open 24/7. They know that you can't say anything different. So they use your facilities. That's the thing any parent would do to take care of their children. Well, under the Affordable Care Act, 32 million more people will have different options available, which we think will be far, far less costly. And give better results, quite frankly, because you enter the system in a less acute stage. All that, we believe, will save money. Universal coverage will bring down the cost of health care in America. Secondly, we invest heavily in prevention and wellness to keep people out of the acute care needs. We do that by reimbursing for prevention and wellness, giving incentives for wellness programs. I often will talk about the program at Safeway supermarkets, where they have a model where their employees could voluntarily join a plan if they take personal responsibility for their own health care needs. If they agree to an exercise program to deal with obesity, if they agree not to smoke, or if they are smoking, to go into a smoking cessation program, take care of hypertension and cholesterol problems for heart disease, manage their diabetes, and do several other areas of self-control in dealing with wellness. If they do that, they get a discount on their health insurance. They also get extra benefits, like membership in a health club. All that's at the same cost, so they're saving money in their health care, getting more benefits, and they share the savings. And for 2 years in a row, there's been no increase in costs for the employees that are in this Safeway plan, unlike the general plan that has gone up at about 5 or 6% a year. Good deal. We incorporate that model into the Affordable Care Act to allow employers to work with their employees to take control of their own life decisions that can help with wellness and prevention. I take some pride in this because I authored the bill in 1996 that expanded Medicare from an insurance program that took care of seniors' illnesses and injuries to one that dealt with prevention, for the first time putting comprehensive prevention benefits in the Medicare system. We ultimately passed that in 1997. It provided for the first time screenings such as colorectal screenings, pap smears. It put into the healthcare system diabetes and osteoporosis screenings and the prevention tests. And it saved us a lot of money in Medicare. We want to build on that, to make the prevention services available more broadly to the people in our community. The Affordable Care Act uses information technology in a more aggressive way. I was surprised to learn, and Maryland's one of the most progressive states in the country on making information available. But in Maryland, if you need emergency care, the likelihood that that emergency physician can get all the tests necessary from your medical records is minimal, unlikely. As a result, the surgeon or the emergency room physician needs to order additional tests in order to know about you. Whereas if we had seamless technology, that information may already be available, giving more timely information to the doctor at less costs, better outcomes, less expensive. information technology can be used in a much more aggressive way to provide the information necessary for the medical personnel to successfully handle medical needs. The Affordable Care Act also deals with disease management in a way to bring down costs, also deals with the issues that you were talking about earlier, with hospital infection issues, readmission issues. Those types of matters are given strong financial incentives to bring down readmissions. We're looking at ways in which we work with the family doctor to make sure that individuals who are released from hospitals have the information they need to take care of their needs. Sometimes there's no one else around. We might have to actually bring in a nurse to try to work with them to bring down readmissions. It's worth our while to do that, to provide those types of incentives so that individuals have the best opportunity to avoid costly readmissions. Ron mentioned the health disparity, and I want to just mention that a little bit more because health disparities in America are shocking. In my own town, in my own state of Maryland, the infant mortality rates for African American infants is almost 3.5 times higher than it is for the white population. That's in Maryland, the wealthiest state and the wealthiest nation in the world. There's no reason for those types of disparities in our state. When you look at fatalities from heart disease, and you look at the rates among African American women, it's shockingly high compared to the white population. And the list goes on and on and on, give you a lot of different disparities that we have. It's also within the Latino community. It's also, you see it as far as economic issues. One of the areas I got directly involved with was oral health care as a result of the death of DeMonte Driver, a 12-year-old from Prince George's County, Maryland, whose mom wanted to get him to a dentist because he had a toothache. No dentist would treat him, had no health insurance. She tried. She even went to a social worker. Social worker tried. Still couldn't get him to a dentist. As a result, ultimately, she took him to the emergency room because he was complaining about headaches. As it was, the tooth, which had become abscessed, the infection went into his brain. He had emergency surgeries costing $250,000, and he lost his life, whereas an $80 tooth extraction would have taken care of the issue initially. So we look at oral health care, and Maryland's done a great job in the last few years to improve access to oral health. We are actually ranked now #1 in the nation on access to oral health, #1 in the nation. I think we can be proud of that. But my point is very clear. If you have access to this care, you can significantly reduce costs and improve outcome, and that's one of the issues that we want to see happen. In the minority community, the amount of tooth decay is much, much higher than it is in the white community. So it's the #1 disease among children, and it's the #1 preventable disease among children. And the disparities along the socioeconomic areas are very clear. We can do better. I've been working very closely with Secretary Sebelius, the Secretary of Health and Human Services in Washington, to do something to make it more, deal with the disparities. The new Institute for Health Disparities in Washington, we think, can go a long way. The bottom line is a lot more needs to be done. The Affordable Care Act was the beginning. A lot more needs to be done. In Washington, we will be taking up issues such as the sustainable growth rate for physicians and Medicare. We need to give predictability to the medical profession. I don't know how you go out and attract young people into the medical profession when they look at all the uncertainty that now exists in the medical profession. There's easier ways to make a living. And if we don't deal with the cost of medical education and deal with the uncertainties of reimbursement, it will have an impact on our workforce. We need to build the right medical infrastructure, not only to qualified health centers, but also have a workforce and a graduate medical education system that encourages the very best in all the areas that we need in the proper type of a workforce to deal with quality and cost in health care. These are challenges that we face, and we will not be able to solve them unless we work together. I want to tell you, I'm optimistic that we'll figure out a way to do this. I really do. I think the nation that has given us Johns Hopkins University, a nation that has given us some of the greatest talent in the world, a nation that has given us the type of people that are in this room today, who are dedicating their life to helping others, that we'll figure out a way that the nation that has the highest health care quality in the world, the United States of America, can also be the nation that has the best health care system in the world. And that's what I look at this conference as achieving, looking at a way that we can take the best health care quality and turn it into a nation that has the best health care system in the world, so that every American has access to the highest quality, most affordable care that can be given anywhere in the world. Thank you for being part of the solution. Thank you for getting involved. I'm proud to represent you in the United States Senate.
I want to thank Senator Cardin extensively for a great inspirational address that will lead us into discussion of our panel of topics pertinent to actually establish a better healthcare system. I'd first like to introduce our panel, going from my immediate left down. The first panelist will be Faizan Abdullah, who is an associate professor of pediatric surgery here at Johns Hopkins University School of Medicine and a leader in surgery and advanced laparoscopy for infants and children with congenital anomalies. He also serves as an outside expert consultant for the World Health Organization. Sitting next to him is Sean M. Berholtz, who is also from the Johns Hopkins University School of Medicine. He's an associate professor at the Johns Hopkins University School of Medicine in the departments of anesthesiology, critical care medicine, and surgery, and the Bloomberg School of Public Health in the Department of Health Policy and Management. He has authored more than 70 articles in the field of patient safety and quality and served as a co-investigator for a successful Keystone ICU collaborative to reduce hospital-acquired infections in more than 100 Michigan intensive care units. Sitting next to Dr. Berholtz is Tom Genowit, who is currently chief of the Division of Trauma and program director of the residency program in general surgery in Sinai Hospital of Baltimore. He is also assistant professor of surgery at the Johns Hopkins University School of Medicine. His interests include the systemic inflammatory response, or the SIRS response, sepsis, respiratory failure, ventilator management, and hospital-acquired pneumonia, as well as healthcare economics and cost of care issues. Sitting next to Dr. Genowit is Elliot R. Hout, who's an associate professor of surgery at the Johns Hopkins University School of Medicine and the Department of Surgery's Division of Acute Care Surgery and director of the Johns Hopkins Hospital's Trauma and Acute Care Surgery Fellowship. His research relates to the prevention of venous, thromboembolism, and trauma systems, education, and care delivery models. Sitting next to Dr. Hout is Patricia L. Turner, who's a minimally invasive and laparoscopic surgeon at the University of Maryland Medical Center and an associate professor of surgery at the University of Maryland School of Medicine. She has emerged as an innovator in quality improvement and outcomes research, and her role as the American College of Surgeons National Surgical Quality Improvement Program, ACS-NSQIP, Surgeon Champion for University of Maryland Medical Center, provides opportunities for prevention of complications and quality improvement interventions on both large and small scales. Sitting next to Dr. Turner is Deborah J. Baker from Johns Hopkins Hospital Department of Surgery. Deborah Baker is the Director of Nursing for the Department of Surgery at the Johns Hopkins Hospital. She is a certified acute care nurse practitioner and part of the steering committee, which oversees the patient and family-centered care initiatives at the Johns Hopkins Hospital and all affiliates. She also co-chairs the Perioperative Safety and Quality Committee. So now I'll ask each panelist to take a few minutes to provide a statement on quality improvement, and following that, we'll take any of your questions. We'll first start with Dr. Abdullah.
Respected Senator Cardin, President Peterson, Dr. Freischlag, esteemed colleagues and friends from neighboring healthcare facilities, it's my distinct pleasure to address you this afternoon as part of the Inspiring Quality Forum for the American College of Surgeons. Let me begin by taking you back to one of my clinics just a Tuesday ago. A set of young parents came to see me as their unborn baby had been diagnosed with a severe congenital malformation. This would require surgery after the baby was born. I walked into the room to meet these parents for the first time, and I looked into the mother's and father's eyes, and they were both full of emotion. In fact, what happens in that clinic room, which is on the ground floor of Rubenstein Building, really was quite astounding if we stop for a moment and think about it. Although I had never met them before, somehow this expectation had been built when they heard about me as a surgeon, about the reputation of the hospital. However it came about, regardless, there was an expectation conveyed to me that in that single instance, in that single look, that I was the pediatric surgeon who they would be placing all their hopes in to fix the congenital malformation of their unborn child. In that moment, in the emotion of those eyes, there is an implicit promise taken from me that I must do everything in my power to help make the baby better. From that moment we met, in their manner of speaking, the sincerity of their expressions, and now it all conveyed a joy of the relationship having been established, along with a growing expectation of success on my part. Amazingly, this new relationship materialized within seconds in that clinic room. It hadn't been there seconds before I walked in, and both I and those parents will never be the same again as our destinies are intertwined in the medical outcome of their new baby. As amazing and scary as it is to be the physician entrusted with such an awesome responsibility of the future of that child, by no means do I have a monopoly of such relationships and expectations of performance being conveyed to providers. The reality of it is that such relationships are being formed by every type of hospital provider, every moment of the day around this hospital, as well as the hospitals around the state of Maryland and all across this great country. Furthermore, this expectation that we will do everything applies not only to us as individuals, but to us as a hospital system. As a surgeon champion for the pediatric nurse equip program here at Johns Hopkins, as well as working on the program nationally, I see the American College of Surgeons NISQUIP program as a direct tool for all surgeons in children's centers to help ensure that we deliver the best results after surgery for each one of these parents and children every time. In the 1 year that the program has been instituted here at Johns Hopkins and rolled out nationally to over 30 children's hospitals, the program has already served as an opportunity for surgeons of different specialties, neurosurgeons, orthopedic surgeons, ENT surgeons, urologists, to all sit down together and focus on how we can improve operating room performance, outcomes, and minimize complications. The program compared surgeons of varying specialties at every hospital so surgeons can feel that they're being fairly judged against other surgeons that are their peers. With a robust amount of data being collected for each patient, we surgeons know that the data is risk adjusted so we don't get penalized for taking care of sicker patients. By having an independent reviewer, we know that we can have the confidence that the data is being collected in an unbiased fashion. All of our surgeons across all of these disciplines, we have meetings where we have an opportunity to double check the data and verify it. This besides the external verification processes the college also has in place. Once we have the data, we feed it back to the surgeon, the nurses, the relevant hospital departments, to whoever was involved in the care of that patient, so hopefully we can do it better each and every time. Thus, I hope I've given you an idea of what we're trying to do in terms of implementing the guiding principles of continuous quality improvement here at Johns Hopkins. It is our hope, with a rigorous programmatic approach as offered by the American College of Surgeons Pediatric NISQUIP program, along with the unwavering commitment of our world-class healthcare professionals, that will be able to better meet the expectations of success of every single parent, for every single patient, every single time. Thank you.
Thank you, Fasan. Dr. Barinholtz.
Senator Cardin, President Peterson, Dr. Freischlag, and representatives from the American College of Surgeons, I thank you for allowing me to share some of the work that we've been doing to improve care in the surgical patient population. You know, one area of field of patient safety that has gained increased attention over the past 10 years or so is that of healthcare-associated infections. These infections indeed are amongst the most common complication of hospital care. They take more lives every year than HIV and breast cancer combined, and a significant proportion of these complications occur in surgical patients. 2 infections specifically, central line-associated bloodstream infections and ventilator-associated pneumonias, account for more than 2/3 of all deaths due to healthcare-associated infections in this country. Just over 4 years ago now, we published the results of a Keystone ICU program demonstrating unprecedented reductions in one of the most common healthcare-associated infections, central line-associated bloodstream infections. The Keystone ICU project was funded by the Agency for Research and Quality, led by our Hopkins research team in partnership with the Michigan Health and Hospital Association. All adult ICUs in Michigan were invited to participate, and the results indeed were unprecedented and dramatic. Across more than 100 Michigan ICUs, there was a 66% reduction in these infections. Now, since that publication, we've made some important progress to advance this science and to work toward eliminating these infections. First, we know that sustaining these kind of improvements in patient safety is a significant challenge. Yet, in Michigan, we now know that these results have been sustained for more than 3 years. Second, we know that implementation of the ICU program was associated with significant reductions in all-cause mortality. Amazingly, the vast majority of ICUs in this country have no idea what their ICU mortality rate is. If they've been participating in the NSQIP program, certainly we would have that data. That data was not available, so instead we reached out to Medicare data looking at all adult patients greater than 65 admitted to any hospital, any ICU in any hospital in the state of Michigan, whether they were participating in the program or not. Compared to over 350 surrounding hospitals, there was a 10% reduction in mortality amongst Michigan hospitals. The vast majority were in the surgical patient population following the implementation of this ICU program. Third, we also know that these results can be replicated. Rhode Island, in fact, was the first state to replicate the Michigan results. Over 100% of their, or rather 100% of their ICUs participated in this project, and they as well achieved a 74% reduction in bloodstream infection rates. And we are now working to disseminate this BSI intervention to all 50 states as part of a program called On the Cusp, Stop BSI. There are 47 states, including more than 1,500 hospitals, participating. Preliminary results from 4 cohorts, 32 hospitals and 32 states and 750 hospitals were just released at the beginning of this month, suggesting that there was a 35% reduction in bloodstream infection rates. And finally, we know that this approach can be equally as effective for other healthcare-associated infections. In the same Michigan ICU program, for example, teams focused on reducing complications associated with the use of mechanical ventilation, including ventilator-associated pneumonia, the most lethal healthcare-associated infection. In more than 100 of these ICUs, there was a 72% reduction in VAP rates, and again, these results were sustained for up to 30 months. We're now working to update that Michigan intervention, implement it in an additional statewide cohort, and we've recently received finalized funding from AHRQ to pilot test the intervention in 2 additional states. So in summary, I would say that eliminating healthcare-associated infections has become a national priority, and the use of the NSQIP database and the vision of the American College of Surgeons to establish that database helps us in these efforts tremendously. The results of the Keystone ICU and the National CLABSI project suggest that the vast majority of these infections indeed are preventable rather than an inevitable complication. What we don't have in this country to date are broad improvements in surgical care, not to the same extent that we're seeing in the Keystone ICU program. And through the visionary leadership of the American College of Surgery and the availability of the NSQIP database, we strongly support a national program that embraces the principles of the Keystone ICU program to focus more explicitly on surgical care. Thanks.
Thanks, Dr. Barinel. Dr. Ganowitz.
Thank you. I also thank Senator Cardin, Mr. Peterson, Dr. Freischlag, and the college that I can be part of this panel. One of the areas where structured quality improvement and a systems approach to care has made a substantial impact in patient outcomes is trauma surgery. R. Adams Cowley here in Baltimore was one of the first to show that an organized and standardized approach to the care of the most severely ill could save lives. Out of his efforts evolved the Maryland Institute for Emergency Medical Services, MIMS, and a systems approach to EMS and trauma care in Maryland. Today, trauma care is well organized across the country, and the American College of Surgeons and its Committee on Trauma has put forth guidelines for the optimal resources for the care of the injured patient, the former Green Book. This resource guides the accreditation for trauma centers across the country and sets the standards for the care of all injured patients. In addition, the American College has developed standardized courses like ATLS that define how every individual in this country delivers trauma care to the injured patient. Here in Maryland, trauma centers are verified or certified by MIMS using and expanding on the criteria of the American College. The standard for trauma center certification define the required available resources and the standards for quality of care reporting and improvement. All trauma centers in Maryland participate in the Maryland Trauma Registry and most in the National Trauma Database by the American College of Surgeons. In all, between the two tools, we track over 100 quality indicators and important information on diagnosis and demographics on a concurrent basis on every trauma patient. While the Trauma Registry allows us to compare the centers within the state and perform quality assurance through the state officials, the National Trauma Database allows us to benchmark the care here in Maryland with the centers across the country. Both tools track data regarding the standard of care delivery. For example, the time between arrival of a patient and CT scan and ICU admission for traumatic brain injury, the time from arrival to definitive care in the operating room for abdominal or orthopedic injuries, and the time for arrival of specialist consultants, among many other things. Analysis of this data allows the hospital to assure allocation of optimal resources and to track process performance. To give you an example, in our hospital over the last 5 years, we looked at the admissions and throughput in the ICU for trauma patients, and we revised our process, leading to a reduction of the time between admission and ICU, between arrival at the hospital and ICU admission for over 3 hours to under 1 hour and 30 minutes. A review of the outcomes in traumatic brain injury has led us to revise our policies, involve a neurointensivist, and create a post-concussion follow-up program that has improved the care for patients with traumatic brain injury. In addition, the Trauma Registry and NTDB track important data regarding specific outcomes and complications. For example, deep vein thrombosis, infections like urinary tract infection and pneumonia, and other potentially adverse outcomes. This allows each trauma center and the system as a whole to gain insight into the quality of care rendered to each individual patient. Again, in our hospital, through a systematic review related to the issues of DVT and hospital-acquired pneumonia, we were able to revise the prophylaxis and management for the patients at risk and substantially reduce the incidence of these adverse outcomes. A substantial body of literature now supports the use of systematic data tracking and benchmarking, and this leads to an improved outcome for individual patients, patient cohorts, a reduction in hospital length of stay, ICU and other resource utilization, and cost of care. The trauma center verification or certification process ties all of these elements of standard setting and quality improvement together. Here in Maryland, every 3 to 5 years, each trauma center is reviewed by MIMS, and a panel of outside reviewers representing trauma physician leaders, nursing, and QI staff perform an on-site, in-depth review of each trauma center to evaluate the substantial compliance of each center with the requirements set forth by the state and American College. To pass such verification, each center undergoes a rigorous process of preparation, internal review, to assure that all the requirements are met. So, the process of standard setting for resources and training, ongoing quality reporting and benchmarking, and formalized trauma center certification here in Maryland represent the pillars of a systematic accountability for patient care outcomes and cost reduction. Thank you.
Thank you, Tom. Dr. Hout.
Hi, good afternoon. I'm going to talk to you today for the next 5 minutes about the issue of venous thromboembolism. And for the clinicians in the room, you know this comprises pulmonary embolism and deep vein thrombosis, which are, to the lay public, are blood clots. And these are killer blood clots. They affect a huge number of patients throughout the United States. Some data suggests that it affects 2 million patients per year in the United States. And according to the Surgeon General, who recently put out a call to action to look into this major project, or this major problem, says that there's over 100,000 deaths related to venous thromboembolism within the United States. According to the AHRQ, Agency for Healthcare Research and Quality, this is the #1 preventable cause of in-hospital death for patients that we take care of. And we know that surgical patients are at extremely high risk for blood clots such as this. Medical literature is robust in what we can do to help prevent these. Not every single one of these blood clots can be prevented, but we do know that prevention techniques can cut the rate substantially and make a huge difference on outcomes for patients. However, when you look at patients and look at their information and find out are they getting the right prophylaxis, are they getting what they should be getting to prevent DVT and PE, the answer is no. Only about 50% of patients, whether you look at the United States, whether you look at top-ranking hospitals, even such as Johns Hopkins, or around the world, around 50% of patients are getting what they should be getting. And we as a group think that's unacceptable, and we need to do a better job of delivering what we know is best care to all the patients that need it. So what have we done in relation to that? So I'm going to tell you first what we've done here at Johns Hopkins Hospital. I work with a collaborative group of medical physicians, nurses, pharmacists, quality improvement people, and our collaborative group has worked with the IT groups here to make a huge dent in the problem. We have implemented a mandatory risk stratification tool into our computerized order entry system. So every patient, when they get their hospital orders written, must go through this screening protocol to decide what risk the patient is at. And then we implemented what we call a smart order set. So the computer asks a few key questions and gives the provider kind of a checklist of risk factors and contraindications, and then uses that data with a flow diagram and best practice, spits out the answer of what we should be doing to prevent DVT and PE in patients. And I can tell you that when we look back at the data to see how well we're doing for giving patients best practice prophylaxis, our rates of compliance have gone from, on some services, as low as 20, 30, or 40% to well over 90 to 95% compliant on many services at Johns Hopkins Hospital. So we think at a single institution we've made a huge difference. So the second question is, what are we doing about this nationally? On a national agenda, people know about blood clots and they know about deep vein thrombosis and pulmonary embolism and think of these as never events. Think of these things that can be prevented all the time. And the first thing I would tell you is that that is not necessarily the case. Even the best practice, highest quality research studies that are done have event rates that are 1 or 2 or 3 or 5% depending on the type of patient. These events are potentially going to happen. So then we ask that question of, well, Medicare now uses this definition of preventable complications and withholds payment for certain complications, including DVT and pulmonary embolism after certain orthopedic surgery. We, however, have a question of is that the best thing that we should be doing? And we're actually actively working with medical directors at CMS to see what we can do in that regard. The second thing is maybe there's a better definition of preventable harm. We agree that if we don't give the best practice prophylaxis and a patient gets a fatal pulmonary embolism and dies, that is preventable harm. We should have done a better job. We should have given the best practice prophylaxis. But what if we do give the best practice? What if we give everything we should? There's heparin doses, there's other things that we can give. What if we do give all that and patients still have a bad outcome? Is that really preventable? And that's a question that really still needs to be answered. And I think what we need to do as working with the American College of Surgeons is help make those definitions of preventable harm and see how we can improve care for all patients. Thank you.
Thanks, Elliot. Dr. Turner.
Good afternoon. I'd like to add my appreciation to those of my colleagues here, to the American College of Surgeons, and to Dr. Freischlag for the opportunity to share some thoughts with you this afternoon. And also would like to thank Senator Cardin and President Peterson for your comments, because I think you framed the debate, or not the debate, but framed the discussion for us very nicely. I wanted to highlight a couple of things that NSQIP does bring to the table that we do at the University of Maryland, ways in which we feel like we are serving our patients better as a result of participation in the ACS NSQIP program. And wanted to start with something that's been mentioned before, but the importance of the notion of risk adjustment. For the physicians in the room, we all think that we take care of the sickest patients. Our patients are always the sickest patients. And the reality is that when you are comparing complications, when you are comparing outcomes, you are not always comparing apples to apples. There are sicker patients and there are patients who are more well, and their complication profiles are going to be different. And so if the data that we collect is not appropriately reflecting the fact that there are sicker patients who may have different outcomes, then we are doing ourselves and our patients and our institutions a grave disservice. And that is one of the things that ACS NSQIP does for us very nicely, because there are hospitals that incorporate all manner of patients, and we are able to risk adjust the data that feeds back to any individual institution in a way that allows us to make an accurate assessment. Another thing about having good data, if there are not well-collected, rigorous data, and certainly I think everyone would agree that ACS NSQIP is probably the best data that you are going to find. It is collected by an actual nurse who goes around with clinical acumen to review charts, to make phone calls, to send letters, and that is head and shoulders better than what we had used before, which are administrative data. Those are data gleaned from billing records, perhaps by someone with no clinical acumen. And there is no question that if you have better data, more accurate data, then you are able to make better assessments. And so the difference between using a database from an administrative billing set of information to what we have with NSQIP is really night and day. We were fortunate at the University of Maryland to be associated with the Baltimore VA, and the Baltimore VA was one of the very, very early institutions, and Barbara Bass, who was one of the early NSQIP champions, was at our institution for a time. And so at Maryland, we've had a very long history, and I think what I would say about that is that the college, the American College of Surgeons, clearly had the vision to know that these data were critically important and that they should be rolled out in a national fashion. So not just at the VAs, not just to the academic institutions, but to institutions small and large, academic and community, VA and non-VA, and those are critically important points. Another point I'd make is that there is the opportunity to review best practices from other institutions. There's a national NSQIP meeting. We all go to that meeting. Those of us who are the NSQIP surgeon champions or have an interest in this sort of thing, we are not protective of our best practices. At the meetings, we share what has worked at our institution, what has worked for DVT prophylaxis, what has worked for infection rates in the ICUs, and those sorts of things are shared in an open fashion with other institutions who are then able to protect their own patients. We don't all need to make the same mistakes over and over again. At our place, we're very fortunate. We have an excellent push that has happened in our trauma ICUs, in our surgical ICUs, spearheaded in many cases by our trauma surgeons that have lowered our CLABSI rates to a point where we had no CLABSIs for a number of months in our ICUs. I mean, that's amazing. And that is as a result of a multidisciplinary approach that incorporated the surgeons, but also the nurses, also empowering the patients, also informing the staff who are non-clinical, how to best manage things as simple as how the rooms were cleaned, how the lines were placed in the first place. So that sort of multidisciplinary approach is what you're able to do when you participate in ACS NSQIP, because that data is fed back to you in a way that allows you to implement it across the board. I would make another point about what the senator said. It's in many ways about the money. And the reality is that if you can reduce complications, then you reduce cost, and it is just that simple. For those of us who are thinking about patients one at a time, that's really important, but to those on the Hill, they want to know what are the big ticket, big dollar costs, and I would highlight the paper from Hall et al. That quoted between 13 and 25 billion with a B, dollars of healthcare savings associated with decreasing risk if we were to roll out ACS NISQIP to 4,500 hospitals. Because at any individual hospital, the number of complications per year reduced is thought to be between 250 and 500. If the costs on average are $10,000, $11,000 per complication, then that is significant cost savings that can be appreciated if we were to roll it out on a broad front. And then the final thing that I would mention is I wanted to highlight one of the papers that we were able to participate in and publish that had to do with bariatric surgery. Now, again, it's just one example, but, one of the things that we were able to do was look at the breadth and depth of bariatric surgery procedures done in this country and calculate a nomogram that would allow for any individual patient at the bedside to basically calculate what their personal risk would be. I mean, clearly it's a mathematical calculation, so you're not able to predict the future. On the other hand, to look at 50, 60, 70, 80,000 records and be able to make a calculated prediction for that individual patient at the bedside, your risk, given your age, your BMI, your comorbidities, this is what's likely to happen to you. That is powerful information that we have to share with our patients. And patients want that, and we have not always had those data to be able to share with them. So I think there are a number of things that none of us have really had time to talk about because there's so much that we could say about it, but I think the bottom line is that data are critically important, accurate data are critically important, and that reducing complications reduces healthcare costs and saves patients' lives. Thank you.
Thanks, Patricia. Last but not least, Director of Nursing, Deb Baker.
Good afternoon. Thank you for the invitation, Julie. Thank you, Senator Cardin and Mr. Peterson and all of our colleagues. I think I represent pretty much the frontline staff perspective on quality, hopefully, and much has been said that I could repeat. I think some of the highlights of that are that data is important, and not just in an evidence-based place like Hopkins. It is important. Nurses do ask why all the time, but our patients are asking why. So the data we get from NISQIP and some of our other process databases are really helpful in convincing teams to work together and to stay together. So I see the data as what keeps us together and keeps us going and provides the relevance of what we're doing. Promoting teamwork is the single most effective way to improve the communication that's needed to ensure safety and quality every minute of the day for each patient. That communication we see, some of the models of that communication we have stolen from aviation into healthcare have been very helpful. We know that when teams, every member of the team, I think Dr. Turner said so well, every member of the team, clinical, non-clinical, and the administrative as well, able to speak up and ask the question is really so critical to prevent error. Communication is the single most, barriers to communication is the single most reason people are injured in hospitals. So how do you accomplish that, especially in these big cumbersome systems? Factor in the cost of having all that indirect clinical time that's needed to ensure quality. I think the challenge is, and good data helps to drive this, is to integrate quality in what we do. Quality still resides in rooms, it resides in meetings, but quality needs to really be integrated into the process of what we do every day and what we care about, especially our relationships with each other and with our patients. One of the ways we're able to accomplish this is our CUSP program, which is comprehensive unit-based safety programs that have really been phenomenal in fostering teamwork in effective ways because it's grassroots. Essentially, a CUSP program consists of staff, an executive coach, and a medical champion and a nursing champion, so stakeholders, but mostly staff. And it's one simple question you ask the staff that drives the agenda. What do you think is going to hurt your patient today? Coupled with, would you have your mother in this setting? Would you have somebody you love in this setting? Those two big questions can drive an agenda and form a team and really focus quality improvement. We have many examples here. And our ICUs have been very sophisticated CUSP teams. Mr. Peterson's an executive of one of our teams, and Dr. Wright's, and they're very effective. But we started to do this in the operating room, which is a more diffuse environment, a tough environment where three disciplines are working together for the same goal. And we have an example using NSQIP outcomes data at colorectal surgical site infections for colorectal procedures. That has been phenomenal, where a team has come together to identify what are the issues that they think might be impacting a very high SSI rate, and have put together a bundle of very simple procedures, but with such investment in making sure that they happen each time for every patient. And we've seen a decrease from 29% to as low as 15% surgical site infection, which is a real demonstration of teamwork and safety outcomes. So this is our challenge ahead, and our next step would be include patients in those CUSP teams to inform us better of what we're doing. Thank you for allowing me the time.
Thank you, Deb. Timing is everything, so our final panelist, Marty Macri, just arrived. He's an advanced laparoscopic and pancreatic surgeon and was doing just that before he came in to see us today. He's a national leader in patient safety, and he served in leadership positions for the United Nations World Health Organization and the International Union of Risk Management, and he's a national advocate for transparency in medicine and shared decision-making. Maybe you could wrap up the panel for us, Marty.
No, it's great. It's great to be here, and I love the CUSP program that we're doing here. It's amazing. The staff love it. The surgeons love it. Believe it or not, the nurses love it. People feel like they're being heard. And the American College of Surgeons, I learned from a meeting last week at the offices in Chicago. They really want to roll out CUSP broadly, and they're going to be providing our experience as a toolkit for hospitals to try to do something to bridge those gaps, because as medical knowledge has increased, I mean, my observation has always been that modern medicine hasn't been able to coordinate all these additional services that we have. I mean, I met somebody from Wilmer the other day who specializes in a part of the eye that I've never even heard of before. And you have all these services, and yet we don't know how to we can't keep up with the coordination as well as we can with the growth in knowledge. And I think CUSP is awesome because it just brings people together and asks that amazing question that Deb said, how are we going to harm the next patient? My personal passion is the fact that patients will often choose a hospital based on parking, and yet we've got all these wonderful internal metrics that tell us that we're providing state-of-the-art care here at Hopkins, and other doctors and nurses around the country are as well. But yet patients are still choosing hospitals based on parking and billboards. So we have competition in healthcare, but it's at the entirely wrong level. We need it at the level of metrics of performance. And the American College of Surgeons, and we're one of the participating sites, has this program now to measure outcomes in a risk-adjusted fashion. Believe it or not, the only way to measure outcomes that surgeons celebrate and don't criticize, because they were developed by surgeons. It was developed in the VA healthcare system and by leaders in the American College of Surgeons. So why aren't these outcomes out there and transparent for the public? Well, now hospitals are coming out and saying, we want to make our outcomes transparent because we know we do very well, and it increases the trust with the community. I think that's an exciting area right now for this NSQIP program, National Surgical Quality Improvement Program, that we've been participating in here, and I've been serving on the national committee for, in terms of what are the next steps. And that's really sort of my passion, what I've enjoyed doing, tying the college with our work here at Johns Hopkins. And I think that eventually, 10, 15 years down the road, patients are going to leave with a thumb drive with their operation videotape on it. It's not, can you imagine calling a radiologist and they say, yeah, there's a brain tumor, but you can't see the films. Well, our technology is moving so fast, everything's going to be transparent. And I think we're in an amazing position to be taking the lead with transparency with our outcomes here. So thank you.
Well, let's hear it for the panel. And we're now open for any questions for the panel. I don't know whether Mr. Peterson or Senator Cardin, if you have any questions for the panel as you sat and listened, which we really appreciate you doing, or the rest of the audience if you have questions for the panel. One question I might ask you, Senator Cardin, which we promise won't ask you anything medical, we won't. You mentioned an interest in saving $250 billion, and we actually have similar interests, maybe a little smaller number here at Hopkins in the state of Maryland. How do we engage your congressional colleagues to learn more about these programs? As you heard today, there's lots going on. Do we need to be more transparent, more vocal? What can we do to help to get our message out?
First, let me thank the panelists. I mean, you really, speaking as a person who's not obviously an expert in healthcare, but listening to your explanations of various areas where quality can really be implemented in a way that's going to improve patient care as well as reducing costs gives us great hope. The frustrating part in Washington is that we normally get into these discussions around budget time. So it's always budget driven. How can we save X billion dollars? More so than what is the right health care policy for this country. And the difficulty is that the people who score the budget numbers will not give you credit for the savings that good health care will bring. They give you costs for the extra service, but will not give you the savings for the services being used to bring down extra cost. So we've got to get to a level where we can talk about what is the right policy for this country and then let the results speak for themselves. I think we're ready for that. And I think this type of discussion is extremely useful and helpful. So I'm hoping that we'll take this information, and I assume there's panels that are taking place around the country that are similar in nature, and hopefully we can take this through either CMS or through the different committees to start talking about ways that we can implement these types of practices nationwide. I was very encouraged by what's being done, not just at Hopkins, at Sinai, University of Maryland, but the leadership we have here in Maryland.
Questions from the audience? I'll start off with a question for the panel. As we've been so involved trying to implement more transparency, as Dr. Macri mentioned, and getting everyone involved, how do you engage other physicians, nurses, and healthcare professionals in quality efforts? Is this easy to do, hard to do? Sean, why don't you start off with how you get everybody to participate?
Sure. So I think that's a great question. I think that getting buy-in from frontline staff can be exceedingly challenging, not just because of their clinical responsibilities, but just because we're quite busy. I think that we've introduced this idea of the Comprehensive Unit Safety Program, and I think one of the things that the Comprehensive Unit Safety Program does so well is to engage frontline staff by addressing issues that are important to them. In addition, it gives them an opportunity to express what those concerns are. So just in brief, that Comprehensive Unit Safety Program starts by educating staff on the system-level lenses so they better understand that the vast majority of complications occur not because of individual physicians or nurses, but because of the way we organize our healthcare system. The second is to ask staff, as other panelists have alluded to, how will the next patient be harmed, and what do you think we can do to try to prevent that harm? And giving frontline staff an opportunity to voice exactly what their concerns are. Our staff has a tremendous amount of wisdom. They know how patients are going to be harmed because they defend against it every single day. So asking staff how they think patients can be harmed and their input as to what we can do to prevent that harm goes a long way, frankly, toward engaging staff to participate. And in our experience, this issue, though challenging, is absolutely essential to successful improvement efforts, is to get frontline staff engaged.
Patricia, at University of Maryland, similar as far as getting your group together, not only at the VA, where I practice a bit from time to time, as well as your university hospital?
Yeah, one of the things that we've done that has been fairly successful is when we create an issue, and it may be an issue that arose because of data we got back from NISQIP or whatever, we've identified an issue. As much as you hate to have committees, we've actually found that having co-chairs of committees, a physician and a nurse, working together has been quite effective. And then we populate the committee with representatives from all the different stakeholders. So an example would be, we had some some issues with maintaining perioperative glucose control and temperature. So, I mean, I think, everybody struggles with that a little bit. And clearly that's a multidisciplinary thing. There are the anesthesia colleagues who have to play a piece of that. There's the PACU that plays a piece of it. There's the OR that plays a piece of it. There's a surgeon who plays a piece of it. So, I mean, there are a number of stakeholders. So when we convened the work group around that specific issue, there was a nurse and there was me. I happened to be a co-chair with one of the nurses from perioperative services. But then there was a representative from IT, an anesthesia person, a PACU person, and they all sat at the table. We put out our ideas. The other people shot them down, because they said, well, that's not going to work in our place, because they rolled out the reasons why it wouldn't work. And we came up with a new conclusion that ultimately worked for all of the people at the table. We didn't leave anybody out. And so when it finally rolled out, there was not that, oh, no, that's not going to work. It doesn't, work in my silo. That sometimes happens when you try to have these things drop down from the sky.
Deb, can you mention a little bit more about how to get a patient involved with this? Because many people are sort of scared that having a patient understand they had a complication or that we're looking at something that could be a problem is an issue. We've started involving patients and their families in rounds in ICUs. How is that going to work?
Well, I think it's kind of like the second wave of involving patients. I think the first is what Marty was saying, the service excellence, let them stay in the room, have internet, coffee. But the second wave is really having the patient family engaged in the care. So identifying somebody in the family that is the patient caregiver right from the very beginning and partnering with that person and the patient as the patient heals in care coordination conversations. And we do that variably well in our institutions. Matter of fact, we're just assessing our whole institution to see, where do we do that well as best practice and where can we improve. And most of the best practices are rounding with family, having families on rounds to ask questions or to listen, invite them to be on rounds has really been critical. The second thing that's really very helpful are patient and family advisory councils. Pediatrics has done this very well for a number of years and pretty much have driven this practice. In adult, we've just started ours. And it's very humbling to sit and listen to a patient's experience of what they thought someone was saying to them and how they said it. Simple, low-hanging fruit, things that we can really take back to our teams and improve. But including a patient on a committee, a patient having their record in their hand, I think are going to be really huge landmarks in engaging patients.
Fazan, as a pediatric surgeon, can you comment a bit of how you've just recently implemented NISQUIT, but you have had these interactions involving patients and patients' families for many years now?
Yes, thank you, Julie. I think a byproduct of transparency is accountability. And in the Children's Center, as we've engaged with our subspecialty surgeons, one of the techniques we've used is literally, showed the surgeon's results to himself. There's nobody who's more committed to his own results than a surgeon. So by showing results in a transparent fashion, people become more accountable. They can see that, there's some, there's experts that very much have worked very hard to, take the very best care of patients they can. So when they see the results, they want to make sure the data is accurate. They want to make sure that they're doing the best they possibly can.
So Tom, how did you get your hospital administration involved? How did you help them understand that you needed to improve quality and safety? And what were the key things you did at Sinai Hospital?
I think we were actually quite fortunate at Sinai. The hospital administration had a very open ear to that and was a partner with us in creating a culture of safety, because I think that's really important. Anybody can affect quality improvement and safety. Whether you're involved in patient care or whether you're peripherally involved, you can become part of improving quality, improving safety. And I think that message has to permeate the institution. Second, you have to have the transparency and you have to present people with data, not only the physicians. You have to present the administrators with the data too, because the administrators are in charge of resources, adequately allocating resources, safety improvement staff, the number of nursing staff, other things. And then you've got to bring it back down. Administrative, executive data has to come back down to a Chiefs Quality Council, down to the floor, so that initiatives like CUSP are empowered to know where they need to go. And so you've got to have that horizontal and vertical integration. And I think that's what needs to happen on a hospital basis, between hospitals, in a state, and then ultimately nationwide.
Elliot, what was your key when you got the POE to involve the DVT project? What was the key to making that happen? Because it changed how we did business, there's no question.
I think we had a dedicated group, and it's multidisciplinary, just like Dr. Turner said. It's not just me, one person trying to change things. It's a multidisciplinary group, and got buy-in from leadership and hospital leadership, and it was with very high level at the hospital where the executives agreed that this is an important thing, and then when the POE people hear that coming from Mr. Peterson or Judy Wright or the leaders of the hospital, that this is something that you're going to help this clinical team to work on, that's the way we got all that stuff through. And it's difficult when I certainly don't have the computer programming ability to do any of the stuff that's been done, but there are people on our team that are able to do that. And now, even those people who have no clinical understanding, they know how big a problem this is nationally, and they're involved, and they have a stake in this problem, and they're willing to work hard to fix it.
Right. Question?
Thank you. I have two concerns that I need some help. I'm Director of Quality at Johns Hopkins Community Physicians, and as you know, our patients are leaving the hospital sooner because of insurance and no insurance. Our patients are older. They're having surgery older, 87, 89. You're doing surgery on patients and they're out in the ambulatory settings. And I've got concern in so much as integrating the families. Many of our families in the communities are unable to continue what started in the hospital. And now they're sitting and attending and having their care at our ambulatory settings. So I'm just asking from the panel to give me some insight, actually to help in so much as articles so that I could improve the quality, especially speaking into our surgery, because we are opening up surgical ambulatory settings. So I certainly would appreciate if the panel could address some of those issues. Thank you.
So maybe anybody on the panel want to start with the older patient? I know with my mother, when she had surgery at Johns Hopkins, she stayed with us for 6 weeks afterwards with my dad, and there's no way that she could have gone home. And my husband is a saint because he's the one that took care of them, but there's nothing like having it at home to realize how much care they need. Patricia?
Yeah, one possible place that you could go for resources, the American College of Surgeons has a patient education committee. I mean, there is a committee whose entire purpose it is to generate multi-pronged approaches to educating patients and families. Now, I happen to be a member of that committee, do not chair it, but it's a very robust committee that, for example, has patient information brochures, and we have them in English and Spanish and Mandarin, I mean, in a number of different languages. There are entire packets of information. For example, one has to do with ostomies. So there is an actual ostomy model. There is a DVD. So, when you're talking about having a patient go home with an ostomy, which is something that if you read the data, most patients say they are really not comfortable. As you said, we're having them in the hospital shorter and shorter times. But, I mean, there are literally like ostomy bags they can cut out, they can practice, they can watch the DVD, learn how to manage their ostomy at home, and patients can watch it, families can watch it. And so there are a number of resources. There will be one, I think, on central lines, feeding tubes for the pediatric population, hernia, gallbladder. So I would say that that is one resource. It's certainly not the only one, but a way to engage the patients. And the college has been very attentive to notions of health literacy and making sure that the material is written at the appropriate literacy level for our patients and their families.
Other comments from the panel? Deb?
Just have one more. One of the other strategies, I think, for elective surgeries is having the patient identify some caregiver, some friend, if they are alone, to come in very early and be part of that. In one of our ICUs, they developed a menu of care where a care provider or a family member can participate in the care in the hospital. They can choose to if they want to, anything from bathing to suctioning. So having that hands-on experience caring for somebody in the hospital under the guidance of a registered nurse is really, there's nothing that can replace that. And then transitioning that outside the hospital is another challenge.
And on the systematic level also. I think that the hospitals, one of the provisions in the Accountable Care Act is the concept of accountable care organization. I think we as hospitals are beginning to understand what that means, and that we need high-quality discharges, and that we need to reach out into the community. And so I think from your standpoint, the opposite is true, is to come to the hospital. I think we're more ready now to partner with organizations like yours to have that transition, that seamless transition, to prevent readmissions and to have that high-quality discharge.
Mr. Peterson?
Julie, rather than ask a question, I'd like to make a statement, an observation, if I may, which is that I would like to thank the panel of emerging leaders in this healthcare quality improvement journey for doing two important things today in the presence of a very influential member of the U.S. Senate. The first is, I think you've really reinforced the point very nicely that higher quality care is not necessarily more costly, but in fact may be part of the solution, figuring out how we can deal with this unsustainable cost curve that we're all trying to deal with. And secondly, I think there's a demonstration here very nicely that there are folks like these folks right here before you, Senator, who are very interested in sharing best demonstrated practices and helping to bring to scale, as was suggested in some of the comments, projects that may very well, again, influence very greatly the opportunity to do something about the cost problem, for which I agree with you that that's going to be, like it or not, the name of the game for us as we move forward. So I'd like to just thank you all for very nicely demonstrating those two important things today.
Thank you, Mr. Peterson. Dr. Pearson?
Leadership heading in that direction nationally. That's going to be a hard journey, but we're going to get there. The other thing that they did is to assign personnel to independently review the medical records. Nurse coordinate, they turned out to be mainly nurses, but qualified clinical experts who were able to ascertain accurately whether a complication had occurred and to track that information independently of the providers. That initiative, I think, is essential to collecting good quality data. And I wanted to ask Pat and other members of the panel from the perspective of the American College of Surgeons in this WIP, and also from the institutional perspective, how that is rolled out nationally, and how can we be sure that the data that's being collected is accurate, because without accurate data, we may make less cost-effective choices in how we use our resources.
Dr. Pearson is chief of the VA here in Baltimore, and my boss when I go over there to operate. Patricia, you want to start, or Marty, do you want to chime in as well?
I love the point. I love your point that the only way to get accurate outcomes is to have an independent reviewer, and the NSQIP is the model for that. We know that when we ask doctors, people to review charts, so there's all kinds of inherent flaws in that, and that's why I think that 5 years from now, when somebody goes to pick a hospital, they're going to go online to the hospitalcompare.hhs.gov website that Medicare runs, and they're going to see the admission rate, the NSQIP outcomes, the safety attitudes questionnaire scores on what % of employees at that institution will go there for their own care. And already, in the last few months, I know that the American College of Surgeons and the Center for Medicare and Medicaid Services are partnering so that hospitals that want to make those outcomes, the NSQIP outcomes, available to the public can do so on that official website. So I think that's the only way we're going to get to a point where we really have a free market, and that will overnight transform the healthcare system.
Well, we are at the end of our time, and I just can't thank the panel enough. I hope you're all as inspired as I am, that there's people really caring all across our city and throughout our state. We really appreciate Senator Cardin and Mr. Peterson staying for the entire presentation. We have recorded this, and this will be available for any people at your hospitals or at your clinics to see, and certainly there'll be more of these through the American College of Surgeons. We do have our office in Washington, D.C. at 20F Street, and we certainly certainly will make sure all this information gets conveyed to you and others making the decisions. So thanks again for a wonderful panel and a lot of inspiration to take care of our patients even better.